Good evening. In another 10 or 15 minutes, we'll be discussing urinary tract, genitourinary infections in diabetes. Since the arrival of SGLT2 inhibitors, the urinary infections which anywhere were a problem in patients of urinary tract diabetes have become extremely important entity. So, in another 50 minutes, I'll discuss the importance of genitourinary tract infection in diabetes. So, we'll start with a very brief about how hyperglycemia leads to impaired immunity with macrophage, CD4 lymphocytes, and some chemokines. In a patient of diabetes, there is a high susceptibility to recurrent infections. It could be urinary infection, it could be skin and soft tissue infection, but it is basically uncontrolled sugar which leads to propensity to recurrent infections. We all know cellular and humoral immunity, and what happens to that when there is diabetes? There is an involvement of cytokines, there is involvement of complement system, neutrophils and macrophages, which get impaired in patient of diabetes, leading to increased susceptibility to bacterial infections. And then you have change in adaptive immunity, cellular and humoral immunity, dysfunction of T cells, impaired humoral response, leading to breach in the barrier, which prevents infections, leading to recurrent infection. In fact, diabetes and infections have a vicious cycle. Improper diet, inadequate sugar control, effects of therapy, cytokine function impaired, impaired T cell function, impaired humoral immunity, innate immunity, coexistence of neuropathy and vasculopathy leads to high incidence of infection in a patient of diabetes. So what about diabetes? What about urinary tract infection? Any urinary infection anywhere requires a base, which could be age, sex, pregnancy, poor hygiene, sexual exposure, previous UTI, and diabetes. So these are the reasons which lead to UTI in any other person. In a patient of diabetes, it is the immune dysfunction, organism-specific factors, and complications of diabetes like diabetic cystopathy, that and impaired immunity, which in turn leads to high risk for urinary tract infection. So, a glucosuria 1 and bladder dysfunction, impaired host response, and adherence of bacteria to uroepithelium predisposes a patient of diabetes to urinary tract infection. As is well known, diabetics have a higher prevalence and incidence of urinary tract infection. Mainly in females, the male to female UTI ratio is 4:1. 40% of patients of diabetes develop UTI, while females predominate 63%, 36%, one third of the patients are males. In females, there is a very high prevalence of asymptomatic bacteriuria when there is existence of diabetes. As diabetes advances, if the diabetes is of longer duration, let's say 10 years, the chances of a diabetic getting urinary tract infection are high. Also, when the patient is on certain drugs, mainly SGLT2 inhibitors, we'll discuss that in later. The relationship with degree of glycemic control, whether FB, PP2 are very high, A1C is high, is ambiguous. There is no clarity. But obviously, a patient who is poorly controlled diabetes, whose A1C is very high, above 8.59, he has a higher propensity, he or she has a higher propensity to develop diabetes. So duration is important. Glycemic control is not that important. Males have less UTI, females have high. This is a study, a multi-centric study. And if you look at the prevalence, it is close anywhere between 6 to 33% in various patients of diabetes. This is a multi-centric. If you have to summarize, the odds ratio of diabetes in type 2, which is what we are going to deal day in, day out, is 1.24. So 24% more chance of type 2 diabetic to develop diabetes. And the commonest organism is E. coli. And then there is Klebsiella, Proteus, Enterobacter, and so on. But this is the commonest. Now, what about asymptomatic UTI or asymptomatic bacteriuria? By definition, asymptomatic bacteriuria is presence of more than 10 raised to 5. There is some spelling error, or more colony forming units, CFU, of the same uropathogen, let's say E. coli or Proteus or whatever, in two separate consecutive clean voided urine specimens in the absence of symptoms referable to urinary tract. So when you take two samples twice, clean samples, the patient will show more than 10 raised to 5 colony forming unit of one organism, and the patient would not have any symptom of burning urine or so. Diabetics are the largest patients having asymptomatic bacteriuria. It's very important to screen them for prevalence of asymptomatic bacteriuria. In a male, the symptoms or asymptomatic bacteriuria is not so common. In females, it is 2 to 3 times more common as compared to non-diabetic females. And the disease is more commonly in the lower urinary tract. Now, if you look at the difference, we saw that it is more common in females, and those females having diabetes of long-standing duration have 2 to 3 times more likelihood of asymptomatic bacteriuria. Now, what about recurrent urinary tract infection? Because of recurrent inflammation, impaired host immunity, disruption of the endothelial, there is a likelihood of recurrent urinary tract infection, more so in a patient of diabetes. Now, what are the genital infections that we see? We discuss the urinary infection. They are balanitis, melanopostitis, urethritis, epididymoarchitis in a male, and in female vaginal infection, pelvic inflammatory disease, and genital warts. Now, what about SGLT2 inhibitor? There is a lot of literature of SGLT2 inhibitors. They are now in mainstream in management of diabetes, have immense benefits, cardiovascular benefits, renal benefits, benefits in heart failure. It is seen that a patient of SGLT2 inhibitor, there is a marginal increase in urinary tract infection, but there is a very high increase in genital infections. So the rise in urinary tract infection is marginal to the tune of 25 to 50%, but there is almost 3 times higher chance of genital infection and if you look at large studies, this was a large cohort of almost 37,000 patients, and it was seen that the risk factor was almost 13% more in patients of diabetes. When you put the patient on SGLT2 inhibitors, there is poor neutrophil mobilization, there is delay in inflammatory cytokine response, there is enhanced adhesion ability, increased growth rate of pathogens, and there is gene expression alteration leading to SGLT2 inhibitor induced urinary tract infection. We all know benefits of SGLT2 inhibitors, cardiovascular and renal benefits. But when you put the patient on SGLT2 inhibitors, there is going to be some infections, more genital mycotic infections as urinary infections and Fournier's cancer. And therefore you have to weigh these pros and cons when you treat the patient. A patient who is above 65, eGFR below 60, having proteinuria and diabetic microvascular complications and obstructive urine, for example, a prostate, is more likely to have urinary tract infection. When the patient is obese, uncircumcised man, and concurrent use of sulfonylurea or insulin, there is a higher chance of genital mycotic infection. A female sex would have either of that, urinary tract infection or a genital mycotic infection. How do you manage that? When the patient is already asymptomatic bacteria, does not mean that you don't have to put the patient on SGLT2 inhibitor. If there is recurrent genitourinary infections, you need to wait, watch, and look at the patient. counseling is very important, and you need to tell the patient about the importance of genital hygiene. If the patient does develop urinary tract infection, you need to find out the diagnose it early and treat aggressively. When you reinitiate SGLT2 inhibitor, that I'll show in. So this was a practical consideration for the use of SGLT2 inhibitors. Expert consensus statement mainly from Singapore published last year, which has clearly shown, that there is no convincing evidence that the use of SGLT2 inhibitors is associated with urinary tract infection when compared to placebo or other drugs. And consideration or concerns about UTI should not be a deterrent for initiating SGLT2 inhibitor. And it is not necessary to do a urine culture before putting the patient on SGLT2 inhibitor. There is no contraindication for patients with asymptomatic bacteria, and these patients do not require prior antibiotic treatment. The Asia Pacific consensus clearly says that patients with history of uncomplicated UTI should not be denied the benefits of SGLT2 inhibitors. If patient has recurrent urinary tract infection, you should look for risk factors, stricture, stone, etc. And if they remain UTI free for 1 year, there is nothing wrong in restarting SGLT2 inhibitor. When there is a complicated urinary tract infection and there is a fluid UTI, you need to be very, very careful before starting SGLT2 inhibitors. Nonetheless, all patients should be told about the side effects of SGLT2 inhibitors and possibility of urinary tract infection. So if you look at benefits, large number of patients, I don't know, the pointer is not working well, but large number of patients benefit large with SGLT2 inhibitors as far as heart is concerned, as far as kidneys are concerned. The predisposition to urinary tract infection is very, very low. Roughly 8 out of 1,000 patients will have this problem. The standard advice is that you need to tell the patient is to take care of local hygiene. What are the diagnostic workup that you would do in patients of urinary tract infection? In a diabetic, yes, the standard glycemic status, the fasting PP2, A1C, CGMS, whatever. Urine routine culture, if need be a sonography, CT urography, and whenever indicated, intervention by a gynecologist or a urologist. The commonest species that is seen in culture is E. coli to the tune of 62%. 12%, this is an international study, 12% would have Klebsiella, few would have Proteus, Enterococcus, and other organisms. There are various complications of urinary tract infection that happen in diabetes. It could be emphysematous pyelonephritis, pyelitis, cystitis, renal and peritoneal abscess, and renal papillary necrosis. So these are complications that we should look, and we have had patients of renal papillary necrosis admitted with septicemia and requiring a long ICU stay when they had uncontrolled diabetes. Now, what are the drug modalities or treatment that we need? We all know in acute cystitis, the drug of choice is nitrofurantoin. It still works. Complicated urinary tract infection, everything will depend on culture report. But to start with, there is nothing wrong in starting ciprofloxacin if patient has no sulfa intolerance, cotrimoxazole, and cefuroxime. If the patient has complicated, then we have a lot set of drugs like third generation cephalosporin, and amikacin, and gentamicin, and whatnot, and piperacillin, tazobactam. Entirely depends on the culture report, entirely depends on the renal function and the patient's response. So in case of genital infections, most commonly they are fungal infections, and they would require antifungal treatment, either local or systemic, either fluconazole or other drugs. For patients, how to prevent that is to advise them to take a lot of fluid, take care of local hygiene, and not to sort of neglect symptoms when there are presence of burning or so. What else? Oh, sorry. So if I have to summarize my talk, sorry. The increased risk of UTI in diabetic individuals is attributed to changes in host physiology because of diabetes and immune impairment due to hyperglycemia and glycosuria. The percentage of various uropathogenic bacterial genera causing UTI is similar to that in non-diabetics. So yeah, like E. coli is predominant even in non-diabetic. Diabetics, it is E. coli. Although presence of diabetes increases susceptibility to drug-resistant organisms, female sex and advanced age increase the risk of UTI in both diabetic and non-diabetic individuals. Thank you.